All right. And hi, Cheryl. Thank you again. Hopefully I did my introduction well, but thank you for the training today, and it is all yours.
All right, thank you. Good evening, everyone, and thank you so much for having me tonight. Today's presentation is on what parents need to know about children's mental health. The objective for today is to be able to help you understand the different childhood mental health diagnoses that there are, the criteria, the identifying signs of childhood mental health disorders, help you understand what to do in response to any signs that you might believe your child may have, and also understand types of interventions that there are out there to help these children. So to begin, children's mental health overall has to do with the health and the well-being of the child. We look at the child's mental, emotional, and behavioral well-being. We look at how children's thinking, feelings, and behaviors are affected by their mental health. And we also try to understand how children are handling, coping, and just managing through daily stresses that they may be facing, how they relate or interact with other individuals, and the choices that they make. Among the disorder, we look at serious changes in the manner in which children typically learn, behave, and handle their emotions. So we're looking at daily how they're handling the stresses, the difficulties that they may be facing, whether it's at home, in school, or in their environment. We also look at delays or disruptions in their development. So are they thinking, behaving, socially interacting, regulating their emotions in an age-appropriate manner? Some of these changes or difficulties can be distressing in children, can also disrupt their daily functioning, whether it's at home, in school, or in other social situations.
Cheryl, I'm sorry, just to interrupt for a second. I'm not sure. I know your slides aren't on the screen, so I wasn't sure if your screen isn't being shared with your slides.
Says you were screen sharing?
Hey Ken, they're showing on my screen, buddy.
Okay, then my fault. Then I have some kind of issue on my end. So you're good then.
I'm good? Okay.
Yes.
All right. When we talk about childhood mental health disorders, there's some barriers that I would like to discuss for a moment. Sometimes it is difficult for us to be able to identify what these disorders are, given the age of the child, the development of the child, and also children really do struggle to be able to explain how they feel and what are the reasons that they're behaving the way they do. And some of the barriers that we face are also with the parents. Some parents may be concerned with the stigma that's out there associated with mental health illnesses, the use of medications, the cost, because some people don't have insurance, so there is a cost to treatments, and also challenges to delivery of treatment in terms of whether or not they have the means to get their child to see the doctors or see a mental health counselor. So some of these barriers may make it difficult to be able to identify whether or not a child has a mental health disorder or not. So for today's presentation, there are many mental health disorders, but today I'm going to discuss the common ones that we see on a day-to-day basis, especially for myself here in private practice. And those are attention deficit hyperactivity disorder, anxiety, behavioral disorders, and depression. I wanted to provide some facts regarding mental health disorders in the United States. The data that I'm going to share is between the year of 2017 and 2019. As of right now, data is still being collected as to how the pandemic have impacted the youth of today. So for data purposes, I thought this was very relevant. 9.8% of children are diagnosed with ADHD. 9.4% are diagnosed with anxiety, 8.9% with behavioral problems, and 4.4% with depression. For adolescents ages 12 to 17, some of the diagnoses that we see is depression, substance use, and suicide. So these are important areas of concern specifically for adolescents, again, ages 12 to 17. I'm going to begin with attention deficit hyperactivity disorder. I feel that this is something that's very prevalent, and many people, I think, are confused as to whether or not their child is diagnosable with ADHD. What we look for is significant changes, severe changes. Typically, children do have difficulties focusing and behaving at one time or another. But what we really look for is the severity of these disruptions, and if a child is unable to outgrow it as they get older. And when we start to see disruptions at school in terms of grades, behaviors, that's when we really start to kind of look at it a little bit strongly. And the behaviors are across settings, so it's not just at school. We're looking at home, or also with peers, or in social gatherings, or in sporting events if your child is involved in any extracurricular activities. Some of the signs and symptoms that we tend to look for are often daydreaming, talking too much, fidgeting. Something that's very common is forgetfulness or often losing things, resisting temptation, careless mistakes, getting along with other individuals or children, difficulties with attention, impulsive behaviors, hyperactivity, or some combination of these problems. So ADHD presents itself in 3 different ways. We look at predominantly inattentive presentation, hyperactivity, impulsiveness, or combined presentation. When we look at these areas, we're looking to see if there is 6 or more symptoms in each area. When we talk about combined presentation, we're looking at both areas. The child has to present with symptoms in both inattentive presentation, hyperactive, impulsive presentation. That would be something that we would consider a combined ADHD. So a lot of times when we look at inattentiveness, we're seeing difficulties in organization, paying attention to details, following instructions, being able to follow along in a conversation, distractibility. When we look at hyperactivity, impulsive presentation, this is where we see a lot of children who are excessively fidgeting, unable to control their ability to sit still for long periods of time, talking a lot. In younger children, we'll see these children, it's almost as if they have a motor inside of them where they can't stop. So we'll see them jump, run, climb constantly on items, accident prone, feeling restless, trouble with impulsivity. So again, in order for us to kind of indicate which area we're looking at, we normally try to see if there's a presentation of 6 or more symptoms in each area. If it is inattentive, then we're just looking at that area of difficulties in terms of focus. If we're looking at hyperactivity, impulsiveness, then we're looking at difficulties. Like I said, it's almost like a child who has a motor inside of them that they cannot sit still, can't focus, can't concentrate. So in terms of causes of ADHD, there are no unknown causes or exact factors. Current research says that genetic plays a role. So there are times that if a parent or parents are diagnosed with ADHD, it's a possibility that they can pass it on to their offspring. Recent studies, and there is ongoing research, indicates that early childhood trauma might play a role in it, as well as exposure to trauma early exposure to trauma can play a role. Other possible causes or risk factors could include a brain injury if a child has had a severe brain injury, alcohol, tobacco use during pregnancy, premature delivery, low birth weight, and other things that could be environmental. So such as lead, for example, exposure to it can also, they're indicating that can cause ADHD. In terms of diagnosing ADHD, the first thing that we mostly recommend is a medical exam to rule out any other possible issues. So what we look at is, for example, hearing tests, vision tests, just to make sure that there are no hearing impairments and possibly no vision impairments. There is a checklist for rating ADHD symptoms, and in that part we look at a NICHQ Vanderbilt assessment scale. So this is a scale where we ask the parents questions regarding their child's behaviors at home. A lot of times the assessment is sent, if the child is school age, we'll send the assessment with the parent to the teacher or teachers for them to also complete the assessment. It gives us a better indicator as to what symptoms the school is noticing versus what the parents notice. We do take a history, a childhood history, and a lot of times there may be an interview with the parents. If allowed, teachers will be interviewed, and sometimes the child themselves will be interviewed, just to get a better assessment of what we're really looking at in terms of diagnosing. If you suspect that there are any signs that your child may have possibly ADHD, these are some things that we can look at in terms of interventions and what to do. Developing a healthy eating habit is extremely important. Studies have shown that children eating certain dyes can be affected by the dyes in some of the foods can affect ADHD, carbohydrates, sugars. Most children that have ADHD have a tendency to have like a sweet tooth. So watching out for those sugary items are important to kind of like limit in terms of, or control, I guess, in their eating habits. Participating in physical activity is extremely important. It gives them an outlet to be able to remove, I could say, or like lessen some of the extra energy that they have. So physical activity is extremely important and useful. Limiting screen time, that's also useful as well. Quality of sleep, we'll notice that children with ADHD tend to have difficulties in terms of falling asleep, and they have a shorter span of their amount of sleep that they have. So you'll see some of these children wake up early in the morning, and it's because they had enough sleep. So they can require maybe 5-6 hours of sleep, whereas another child might require 7 to 8 hours. So ensuring that they're getting quality of sleep would be helpful for them as well. Some of the things that I always encourage is speaking to the child's teacher. Again, if your child is school-aged or in a daycare, speaking to that person, whether it's a relative, a caregiver, or a teacher, just to be able to get a grasp as to whether they're noticing any changes in their behaviors is really important. Consulting with your child's primary care physician is important, letting them know that you have any concerns or you've noticed any changes. Also being able to observe and describe those behaviors to your PCP would be really great, because then it gives them a better indicator of what you're dealing with on a daily basis. In terms of interventions, behavioral therapy would be beneficial. If you feel that your child has been diagnosed with ADHD, behavioral therapy would help that child and help you also learn how to be able to manage some of those behaviors. And if in extreme cases, doctors will recommend medications. Now moving on to anxiety disorder. Again, typically children tend to have, just like us adults, typical fears and worries. When we start to see that these worries and these fears start to interfere and become persistent, that's when we start to kind of need to pay attention a little bit more. And when I say interfere, this is interfering with school. For example, some kids might not want to go to school, not because they don't enjoy it, because there's a fear, maybe a social fear. Playing activities with others, if they're fearful leaving home. Again, a child may be suffering from an anxiety disorder. So some signs and symptoms to look for is, and the key word here is persistent. We're looking at persistent fears and worries, which can make the child irritable and angry. Anxiety that disrupts their ability to engage in or participate in typical play in school or any type of typical age-appropriate social situation or extracurricular activities. Some children might have difficulties sleeping. A lot of times we'll see some children have nightmares. They'll indicate that they have nightmares, and it might be from that fear or that worry that they're constantly having. It could also affect them physiologically. So we'll see some kids describe stomach aches as the most common. So a lot of times they'll suffer from a lot of stomach issues. Sometimes headaches and feeling tired, like fatigued. Other symptoms may be missed because a lot of times children are worried themselves to express that to their parents. So a lot of times you might miss some of the symptoms unless you're really watching them. You'll see nail biting, for example. I know some children, especially girls that have longer hair, will chew on their hair. So sometimes we might not physically know that they're worried, but we might see behaviors, that there is some anxiousness within the child. There are different types of anxiety. Some of the types of anxiety that we notice is separation anxiety, phobias, social anxiety, generalized anxiety, and panic disorder. So when we look at separation anxiety, we're looking at, again, looking for certain symptoms that are persistent for at least 6 months in children. When we look at separation anxiety, we're looking at that to be persistent for at least 4 weeks. For adolescents, it's persistent for 6 months or more. And this can be constant thoughts or intense fear about the safety of the parent or the caregiver. So you might notice, you leave your house and your child's maybe calling you as soon as you left, or calling you persistently while you're out running errands just to make sure you're okay. Some children might refuse to go to school, frequent complaints about stomach aches or other physical symptoms, overly clinginess, sleep, worries about sleeping away from home. They might not want to go for a sleepover with friends or with a relative. They want to stay home with you. Sometimes they'll have panic or tantrums at times of separation. So we see this a lot often in younger children. When a parent needs to leave the home to go run errands, the child will cling to them, will cry and scream, don't leave. So we see this more often in younger children. And a lot of times they might have trouble sleeping, or nightmares as well might be reported. In terms of phobia we see in children crying, tantrums, freezing, clinging behaviors. And again, this is extreme fears about a specific situation, thing, object. It can be, I gave examples, there are children that have fears of insects, so they don't want to go outside and play because they're afraid of bugs. I see this often, children being afraid to go to the dentist or go to the doctors, in fear, like extreme fear of needles. So these are fears that cause significant distress or interferes with their usual activities. So that's what we look for when we're looking at phobias. In terms of social anxiety, this we also in younger children, we might see tantrums, freezing, inability to communicate when they're in front of people. And that's what we see in younger children. But in general, we're looking at fear of meeting or talking to people, avoiding social situations, perhaps adolescents that get invited to a school dance and they don't want to go because of the fear of being looked at or ridiculed or all eyes on them. You might see that some adolescents or even children may have few friends outside of the family. And again, it's based on that fear, and we're looking at those extreme fears. When we look at generalized anxiety, these are just worries that they have about things before they happen. So a lot of times something hasn't occurred yet, but they're already worried about it, anxious about it, considering the what ifs. So this is a constant worry or concern that they may present with. And sometimes it can be about family, it can be about friends, it can be about school. You might see signs of repetitiveness, overthinking, and this might look like obsessiveness, where they're constantly thinking about the same worry or about the same situation over and over. Sometimes it could be in actions in terms of compulsion, things that they're doing constantly, pacing back and forth, fear of embarrassment or making a mistake. I see this often, especially in the adolescents, because they're constantly worried about embarrassing themselves in front of their peers or making a mistake in front of their peers. A lot of times we'll see low self-esteem, lack of self-confidence in children with generalized anxiety. And again, with generalized anxiety, we want to see at least 3 or more of these symptoms that are persistent for 6 months or more in order to diagnose. When we look at panic disorders, this is where we also want to see 4 or more symptoms. And again, we're looking at the intensity. So anxiety attack that comes on with an intense physical symptoms, and this includes racing of the heart racing, chest pains, trouble breathing. A lot of times they might feel like they're losing control of themselves. They feel like they're dying. So these are things that we look for, and as well as just feeling that the world is not real. So these are the key symptoms. There are more, but it's very hard to kind of include everything that is written in terms of diagnosing. But these are the main ones that we look for in terms of anxiety and the types of anxieties that we tend to see in children and adolescents. Some causes of anxiety is genetics. Children with parents that have an anxiety disorder are 7 times more likely to develop the condition. Sometimes it can be caused by brain chemistry, so imbalances in serotonin and dopamine. We know that these chemicals are involved in mood and emotions. Sometimes the temperament of the child. So if a child who is extremely cautious, fearful, or shy, they might be more prone to developing anxiety. The environment that they're in or the environment that they're surrounded can also be a cause of anxiety. So for example, if a child is going through a difficult divorce, for an example, illness themselves or an illness in the family, a death of a family can also trigger anxiety in a child. Children that have experienced trauma or stressors in their environment. So for example, bullying is something that's major. So we will see that often in children presenting with anxiety if they're being bullied in school or feeling rejected by their friends. Another thing is a learned behavior. So if parents tend to be, or figures that are around them tend to be overly anxious, sometimes children learn to behave in that manner, to be very anxious and worrisome. Unstable environments as well can cause anxiety. So if a child doesn't have stability, for example, constantly moving, changing schools, dealing with housing issues, even families or children that are homeless and are staying in a shelter can experience anxiety. In terms of diagnosing, I listed several different assessments that there are, mainly generalized anxiety disorder, which is the GHD-7, is something that is used very often. Pediatric symptoms checklist. So the pediatrician, a lot of times, if they ask the children questions, if they feel that the child is anxious, they'll do a symptoms checklist. Comprehensive evaluation is done. Generally, that is conducted with the parent and the child. Interviews with the parent as well and the child can be done individually or together. Again, looking at that symptoms checklist, going over to see how many presenting symptoms there are in order to be able to say whether or not this child is diagnosable with anxiety disorder. And we also like to determine the child's strengths and areas in which the child may need some more support, and will be conducted as well. Things that you can do and interventions. Practicing mindfulness and relaxation techniques is something that is really useful. I tell parents, if you see that your child is experiencing anxiety, helping them participate in physical activities, at least at a minimum 60 minutes. And this can be anything, whether it's a sport, it can be an art activity, it can be crafts, anything that your child enjoys, because it will boost their self-confidence when they are participating in some physical activity or mental activity, like I said, arts and crafts, painting. Quality of sleep is important. Giving your child permission to talk about their worries is extremely important as well. So doing check-ins is what I call with your child. If you notice any of these signs or symptoms, take the time, maybe at bedtime, to ask them how their day was, if there's anything that worries them, anything that they want to talk about. A lot of times, giving them that space to be able to feel that they can come to you to talk to you about the worries can be very helpful. Increasing awareness of how anxiety shows in your child. So kind of, again, being that observer and watching any behaviors that you've never noticed before. If your child has never typically been a child to bite their nails or to put things in their mouth, that's something to kind of like look for. Modeling coping skills is something that's really important as well. So if you yourself are struggling with certain anxieties or worries, typical worries or anxiety, the manner in which you handle them would be a way that you would be modeling for your child how you're coping through those stressors that you deal with. Therapies that there are in terms of outpatient therapy, we look at cognitive behavioral therapy, exposure therapy, art therapy. Those are some of the models that are used to help treat children with anxiety. And if a child is extremely, very anxious, again, considering medications might be something that you would have to talk to with your doctor. The next topic or next disorder would be behavioral disorder. Again, typically children tend to argue, will become aggressive, can act out, and be defiant. That's typical behaviors of children and adolescents. What we look for is when it becomes disruptive, when the behavior is disruptive and is severe and persistent. That's when we start to look at it a little bit more closely and deeply. And a lot of times the behaviors that we look at are externalized. So this is where a child is acting out, showing unwanted behaviors towards others. So some of the signs and symptoms is refusing to follow rules or questioning authority, difficulty handling frustrations, arguing, throwing temper tantrums, easily annoyed or nervous. Some other areas when we talk about conduct disorder, we're looking at refusal to obey parents or again, authority figures, repeated truancy, lack of empathy for others, tendency to use drugs, including alcohol and cigarettes at a very young age. And sometimes we look at being aggressive to animals and other people. So that might include bullying and possibly physical or sexual abuse. So there are other types of behavioral disorders, but two of the most common that we notice is oppositional defiant disorder and conduct disorder. So in oppositional defiant disorder, we're seeing children that are often angry. They lose their temper, often arguing with adults, refusal to comply. We might see this in schools as well, where the child may have difficulties respecting teachers, following the rules of school. Sometimes they'll present with resentfulness or spitefulness towards others, deliberately annoying other people or becoming easily annoyed by others themselves. Often we see them blaming other people for their own mistakes or behaviors. So when we look at these, again, we are looking at behaviors that are constantly present. So the key here is often. So it's not where a child is, once in a while losing their cool. This is something that is persistently seen across settings. In terms of conduct disorder, we're looking at 15, and again, I didn't have the opportunity to write all of them because there's so many, but there are 15 criteria that we look at in terms of behaviors within a 12-month frame. And it's from a category of aggressiveness towards people or animals, destruction of property, theft, and serious violation of rules. And at least one of those areas being impacted within 6 months. So again, being aggressive in a way that causes harm, and that could be bullying, fighting, cruelty to animals. It could be lying, stealing, damaging other people's properties, and this is purposely done, so it's not accidental. Breaking rules, such as running away, staying out all night when they're told that they cannot or they have a curfew. This is skipping school or not going to school for numerous days. So we're looking at, again, severity and persistentness of behaviors, not a child that stood out one night out of the past 6 months. This is something that is often being observed and noted from a child or an adolescent. Causes of behavioral disorders, stressors in the environment. So again, if there's arguments in the home, if the child is going through family divorce, if there's changes within their environment, so that is something that we look for in terms of stressors within the environment. Unhealthy or inconsistent discipline styles. So if a child's parents are extremely strict, and then other times they shift and they're very loose and open and allow their child to do things, so that inconsistency can sometimes cause behavioral disorders, or discipline styles can cause it, because there's no consistency for that child. Unstable relationships. So for example, if a child does come from a divorced family, and a parent is supposed to pick that child up, and constantly that parent is not there for that child, or even relatives, it can cause unstable relationships for them, and it can cause them to act out. Trauma and abuse is something that we see often in children with conduct disorders and also ODD. So a lot of times we look at doing an assessment on that. Exposure to drugs or alcohol can also be a cause of behavioral disorders. We also look at the child's temperament and also their emotional development to see if that can also be a trigger and a cause of behavioral disorders. And difficulties at school. So for example, if a child is struggling academically, they might start to have outbursts or behavioral issues. If a child is being bullied or is the bully, we also kind of look at that as well. In terms of diagnosing for behavioral disorders, again, a comprehensive evaluation is done. So we try to gather as much as information, both individually and together with the parents. A child's history. So we also gather information from birth all the way up until the present age of the child. Any type of medical history that the child may have, behavioral history and symptoms. And again, we try to gather as much information to be able to diagnose. There might be assessments and questionnaires that we might provide to the parents, again, including the school. So we might send assessments to the teachers to gather information of what those behaviors look like within the school setting. Consultations as well with teachers or caregivers, again, just to be able to gather as much information as possible in terms of behavioral disorders. Things that can be done in terms of intervention, or what you can do if you notice that your child is showing any type of signs, is designing a routine. We know that children function much better when there is a routine. So designing a routine that works for your household would be very helpful. Setting realistic expectations. A lot of times as parents, we set expectations for our children that we might believe that they can handle, and it might just be too stressful for them. So setting realistic expectations for them would be extremely important. Consistency is another one that's extremely important. Maintaining some level of consistency, whether it's with rules, discipline styles. So just maintaining a level of consistency with your child. Focusing more on the positive than on the negative. Again, a lot of times, the children are exposed, and I would say most of us are exposed to a lot of negativity out in the real world. So trying to focus more on the positives and not really focusing so much on the negative can be really helpful. Changing communication strategies, again, as a parent, being able to be open to discussion with our child, ourselves being able to be in a calm state, not being aggressive or emotionally like, how can I say it? Emotionally unbalanced, where if we're dealing with stressors ourselves and we're not in the right mind frame, that might not be the right time to talk to our child or communicate things. But when we are in a calm state, be able to be open to communication. Building positive relationships. If our relationship with our children is strained, then kind of reflecting and kind of considering what changes can we make, or what can we do to try to repair the relationship so that we can be able to have a better, healthier relationship and communication with our children. Engaging in regular physical activities is extremely important. And I put in here aerobic, but anything that's cardio, like rigorous exercise, can be helpful to kind of help the child exert some of that excess energy or place some of that energy into something more positive. Quality of sleep again, and a healthy diet is also useful. And lastly, strengthening those relationships with family members. So again, as I mentioned before, building those positive relationships. So if there are areas that you feel or your child has a strained relationship with certain family members, being able to build on those relationships and strengthen them would benefit them as well. Depression. Depression is, this one is a little bit tricky in terms of kind of identifying whether the child may have depression or not, given the fact that a lot of times we see that children are sad or feeling hopeless. But this is when we are seeing this chronically, persistently on a daily basis. And the reason why I say it's tricky is because children can go through bouts of moments where they're feeling low or down, and it could be because they're having difficulties with a peer or a friend, and it might appear that the child may have depression, but it might be situational versus now that we're looking at something that's chronically happening to our child. So one of the key things that I try to look for, and I try to tell parents, is that chronically feeling that helplessness or feeling hopelessness. And again, that chronic sadness or disinterest. So if your child was interested in certain things that they used to enjoy and all of a sudden they no longer have an interest in it and it's persistent, then those are kind of telltale signs that your child may be going through some level of depression. So some of the things that we look for is often feeling sad, hopeless, or irritable. Specifically in children, we look for irritability. For adolescents, we look for any of these other signs that we see, but definitely for children, it presents itself more of anger and irritability than sadness. Not wanting to do things or enjoy doing fun things. And again, that's where I say that this is areas where your child normally would have enjoyed these activities, and then one day they just stopped enjoying it. Showing any types of changes in sleep. And in sleep, we look at both polar opposites. So whether the child is sleeping too much or having difficulty sleeping. So insomnia, interrupted sleep, that's what we look for. Showing signs and changes in patterns of eating. And again, we look at both those polar opposites, where whether the child is eating too much or not eating at all. The same thing for changes in energy. We look at those polar opposites, whether the child is excessively filled with energy that again is not typical for themselves, or completely lethargic, have no energy for anything, don't want to do anything. We look for signs of them feeling guilty, feeling worthless, or they're useless in life, difficulties with focus, paying attention. One of the other indicators is if you know or a peer has mentioned to you, or you've seen signs of self-injury behaviors or self-destructive behaviors. Those are some of the things that we look for as well, especially in adolescence. Extreme depression can lead to thoughts or plans for suicide. So again, I'm not going to go into the topic of suicide. I believe there might be another workshop on that particular topic. But one of the things that I did want to mention was that, especially for adolescents, if we're seeing extreme depression, or we know that we hear them talking about, thoughts of death, or anything of that nature, again, those are signs that we need to kind of pay attention to. A lot of times we'll see, especially now with social media, and I believe there was a workshop on social media. A lot of times some children, and especially adolescents, tend to post things on their social media. So kind of watching out for those signs of any type of thoughts or plans in terms of self-harm or anything like that is really important as well to kind of pay attention to. Again, just like in any of the other diagnoses, I'm only putting down the most prevalent ones that I typically see, which is disruptive mood dysregulation disorder and major depressive disorder. So when we look at disruptive mood dysregulation disorder, this is where we see reoccurrent temper outbursts, and those temper outbursts can be verbal. So it could be verbal aggression, or it can be physical aggression. So whether they're physically fighting with someone or physically breaking items, those are things that we look for. And again, severe recurrent. So we're looking at that to be recurrent behaviors. Temper outbursts that are inconsistent with their developmental level. So if you're looking at a teenager who's having a temper outburst that is not typically consistent with their age, then that's kind of something to look at. Outbursts occur on an average of 3 times or more. So again, this is not a child who had a meltdown because something happened that week and then it never happens again. No, we're looking at this to be an average of something that occurs 3 or more times per week. Again, the mood between temper outbursts is persistent. And what we look for, again, is irritability or anger for most of the day, nearly every day, and it's observed by others. So it's not that you are the one that's noticing it, other people are noticing it as well. And the behaviors tend to be in at least 2 settings, with one setting being severe. And what I mean by settings is that this can be a school setting, a daycare setting, a home setting. So we want to know that these behaviors are occurring in at least 2 minimum settings, with one of them being severe. So maybe the child is having outbursts at home, but they're more severe in school, or vice versa. Again, the diagnosis cannot be made before the age of 6 or after the age of 18. So we're looking at within the ranges of 6 to 18 years of age. In terms of major depressive disorder, we're looking at sad mood, and a sad mood that is most of the day. So this is not, again, typically a child that feels sad momentarily, or just having one day out of the week where they're feeling sad because of something that may have occurred in their life. This is, again, more severe, recurrent sadness, and it's usually something that we notice most of the day. Decreased interest or pleasure in activities that they usually had an interest in. And again, this is persistent. Weight loss or weight gain is something that we look for as well as a telltale sign. Sleep disturbance, as I mentioned before, that can be whether the child is sleeping too much or having insomnia, interrupted sleep, early awakening. So these are things that we look for when we talk about sleep disturbance. Restlessness or being slowed down. And again, this is something that we want to be able to see on a nearly daily basis. So it's not, a child that a couple of days here or there are feeling a little bit restless or tired. No, it's something that we notice more often than so. Tiredness, loss of energy. And again, we're looking at this to be something that is occurrent and is happening nearly every day. With depression, we'll see decreased concentration, inability to focus, a lot of times because they're preoccupied with whatever is bothering them or what is saddening them. Feelings of worthlessness, that's another one that's extremely key for us in terms of diagnosing. Again, as I mentioned before, recurrent thoughts of death or suicidal ideations without a plan or an attempt. So these are just thoughts that they're having about death, not that they necessarily have an actual plan or have attempted to. A common feature is persistent irritability and frequent episodes of extreme behavioral discontrol. And especially we look at this in children again. So this is not so much for adolescents, but in terms of children, younger age children that might be persistently irritable constantly, and we have no clue why they're feeling this way. Causes for depression, again, just as anxiety, it can be chemical imbalances of the brain. So that could be, imbalances in the serotonin and also the dopamine levels, again, because that is associated with mood. Hormonal changes, children that are coming of age and going through hormonal changes, puberty, we might see shifts and changes in terms of depression. Personality, again, if a child has low self-esteem, is overly critical of themselves, that might be a cause, that might be an indicator for depressive disorders. If there's an illness, for example, or disability, a wheel-bound child, that can cause, again, because they're unable to do things that other typical children can do, that can cause depressive disorders, or a child who is chronically sick as well that cannot function as other typical age children. So sometimes that can cause depressive disorders. Genetic vulnerability. Again, if there's a history in the family of depression, again, that can be, it could be genetics where an offspring can have depression. Risk factors can also cause depressive disorders. So we're looking at trauma, again, childhood trauma, exposure to trauma at a very young age, history of family depression, and also stressors. So if there are a lot of stressors within the home, stressors within the school, within their environment, that can also be a cause for depressive disorders. In terms of diagnosing, clinical evaluation, so again, meeting with a doctor, a therapist can diagnose. So again, clinical evaluations, we look at the history of symptoms, a symptoms checklist, again, looking at all those factors of what symptoms they're showing, assessing their daily mood, behaviors, lifestyle habits, screenings and assessments. There are screenings and assessments that can be done, and looking at the medical history as well. One of the things that I always recommend in terms of for medical is always going and getting a medical checkup. I always tell my clients, especially if they come here with their child and they suspect that their child may have depressive disorders, I usually ask for them to go if they've had a recent physical, because a lot of times we'll notice that there might be low levels of vitamin D, low levels of vitamin B. Those are common that I see very often, and that could also be a factor into terms of depressive disorders. So we want to look for those things. Again, ruling out anything medical prior to diagnosing a child with the depressive disorders. And honestly, this goes for any of the disorders that I've just mentioned. A medical checkup is always, I feel, necessary just to be able to rule out any type of medical issues prior to diagnosing a child. And if depressive disorders are extreme, again, one of the things that I didn't add is medications. In some cases, I've noticed that there are some children that can have depressive disorders, which is extremely extreme, then medications will be an option as well. So some of the things that can be done, again, creating a regular routine for this child. If you know that your child is kind of on the low end, feeling sad, kind of like trying to get them out of whatever they're doing, like, come on, let's go out, let's, I have to go run some errands, come with me. So again, trying to encourage them and be supportive. Healthy eating plan as well, participating in physical activities, that can be really helpful. Exercise is extremely important, especially if your child is coping through depression. We know that physical activity can increase, improve the imbalances within the body. Sleep hygiene, again, trying to make sure that the child is getting sufficient sleep to be able to rest their bodies and recuperate. Medical checkups, as I mentioned before, I think it's important to rule out anything that's medical prior to diagnosing a child with any type of disorder. Creating, if there is none, and if there is, just amplifying a positive support system. It's really beneficial when a child has a positive support system, using the family that are accessible to them. So if there's siblings, if there's friends, neighbors, other relatives, so enhancing that positive support system for that child would be extremely important in terms of trying to get them out of whatever place that they're at in terms of sadness or just lack of energy, or it might seem that the child is uninterested, but trying to motivate them. Open communication, I think it's extremely important. Again, maintaining those lines of communication with our children. How was your day? A lot of times when we ask our children, how was your day at school? A lot of them will be like, good, but try to ask more direct questions. What did you struggle with today? What went well today in school? What was a highlight of your day today in school? So that we're opening those lines of communication. Again, in terms of open communication, keeping lines of communication open with your child's teachers. I think it's extremely important to be able to know what's going on. So if you suspect that something may be going on with your child, and this goes again across any of the diagnoses that I've mentioned so far, being able to keep those lines of communication and speak to your child's teachers and find out, hey, I noticed that, Johnny over here has been, he seems to be a little bit more sad or a little bit more down than normal. Is anything going on in school? Have you noticed any changes in his or her behavior? So again, we want to be able to have those type of dialogues and open communication with caregivers, teachers, anyone that's involved in your child's life. Counseling services, again, is a mode of intervention. So a lot of times, as I mentioned before, cognitive behavioral therapy, art therapy, those might be convenient for your child. And again, if at all anything is extremely severe depression, again, looking at medication as an alternative. So what you can do for your child, honestly, I always tell most of the people that I work with in terms of clients is, as a parent, you know your child's best. If anyone is going to know your child, is going to be you. So again, keeping those open communication with your child's teachers, if your child is involved in any type of extracurricular activity or sports, keeping that communication open. Healthcare professionals, if your child is seeing a therapist, speaking with the therapist intermittently to find out how your child is doing. Observe your child if you notice that there are any changes in how he or she is behaving, whether it's at home, school, or with friends. Again, monitoring your child's social media accounts. Pay attention to what your child is posting, especially inspect what your child might be watching, researching, who they may be communicating with via email and or social media accounts. And I know that we're kind of running down on time. So some of the things that I tell people is, in terms of conversations with your child, there are two options that may occur. Either your child or your teen may initiate the conversation with you, or you may want to initiate the conversation with your child. So some of the key points that I say is, if the child or your teenager initiates a conversation, for you as a parent to stay calm and listen. That's a key thing. We need to be able to stay calm and be able to listen carefully, not interrupt the child, allow the child to speak. When they're done speaking, then be able to give feedback. So in terms of understanding, so when we're listening, we're trying to understand what the child may be trying to say to you, because a lot of times it could be really difficult for the child to even start that conversation with you. Validate their feelings. It's a key, and that's something that's really, really important, is validation. Just like we like our feelings to be validated, we also need to validate those feelings of our children. Take a break, especially if the emotions are really high or you're unable to continue to engage in that conversation. It's okay to say, hey, I need a timeout right now, and take that break. If you're the one that wants to initiate the conversation, I will tell you, prepare for the conversation. Take the time to prepare first before you have that conversation with your child. Find the right time and the right place to have that conversation. And one of the things that is very useful is using I statements, so that we're not casting any blame or shame or resistance in the conversation that we're having. And again, just one of the things that I mentioned before, just tips again, is good listening skills, speak calmly and clearly, take breaks if necessary, don't minimize the experience or the feelings that your child may have, reassure them, provide support, listen, stay focused, ask questions. If you're not sure, just ask clarifying question. Can you said this to me, can you clarify? Just don't assume, and reach out to your teachers, guidance counselors, any school staff for resources. So if anybody has any questions, I'll leave this up. That's the Connections Counseling is where I work at. That's the email for our website. We have 2 locations. One is in Stroudsburg, the other is in Marshalls Creek. And if you have any questions regarding the practice, you can send emails to info@connectionscounselingservices llc.com, or you can send me questions directly at Cheryl-Torres at Connections Counseling and Services LLC.com. So I'm not sure if there's any questions that have come through.
Well, thank you, Cheryl. That was a lot of information. Each of these trainings I start with, I can't possibly think the trainer is going to have more information, but with each one we get more and more content. So that was great. I did put in the chat box the survey. People can click on the link and provide us some feedback. That would be great. There were no chats. There's one chat, a person who's just asking about accessing your services. If you see that, you can respond, Cheryl. I'm not sure.
I was trying to, but for whatever reason, it's not on my end. It's not letting me. It actually bumped me out of the presentation.
So, I don't know, but so the person who asked the question, if you could maybe email Cheryl directly, and then that way.
Yes, I'm going to put this. Yeah, it bumped me out. I do apologize. I'm trying to figure out why it did this, but I'm trying to get back to the screen with the contact information. So if anybody needs it, it's a mouthful, the email address. I do apologize.